Hi and welcome back, guys. Today we'll be looking at a major gynecological issue known as cancer of the cervix. We'll begin with the introduction. Worldwide, it is the second commonest cancer affecting females, second only to cancer of the breast. Commonest cancer affecting females in the developing world due to poor screening. The leading cancer affecting female genital tract. Worldwide, about 500,000 new cases annually, 75% in developing countries. About 300,000 women die of the disease annually. So we'll look at the geographical distribution of cervical cancer incidence. So this is the geographical distribution. You can see that it's affecting women worldwide. So what's the etiology of cervical cancer? It is unknown. Increasing evidence that infection with certain strains of human papillomavirus, that's type 16 and 18, is a factor. 80 to 9% of sexually active women acquire infection at some stage in life. Only about 10% of infected women develop cervical dysplasia. Other cofactors play a role. Cofactors like 1. High risk behavior, including early coitus, age at first coitus, early marriage, multiple childbirth, that's high parity, frequent change of sexual partners. Also note that cancer of the cervix is rare among nuns and virgins. Third is male partner. Is your male partner promiscuous? Does it have cancer of the penis? Consult with women that have carcinoma of the cervix. Third is familial predisposition. Do you have close relatives that already had cervical cancer in the past? Fourth is cigarette smoking. Nicotine and other byproducts concentrate in the cervical mucus with reduction in the immunity of Langerhans cells. Immune inhibition in HIV/AIDS, chronic use of corticosteroids. 6 is age mean, which is 51.4 years, 2 peaks 30 to 39 years and 60 to 69 years. Race, commoner among Africans than Caucasians. 8 is socio-economic status, commoner in low socio-economic group, so it's commoner among poor people. To the pathogenesis of cervical cancers. Squamocolumnar junction varies throughout reproductive life. It varies during puberty, varies during pregnancy as well. So transformation zone harbors retention cysts known as Nabothian follicles. So the squamocolumnar junction is that point where the columnar epithelium of the body of the uterus and the squamous epithelium of the cervix come to meet. So at this point where they meet is the transformation zone, which harbors retention cysts known as Nabothian follicles. And it's also here which squamous metaplasia takes place due to high acidity in the vagina. So dysplasia as a result of high acidity in the vagina at the squamocolumnar junction due to infection by human papillomavirus plus cofactors such as early coitus will result into cervical intraepithelial neoplasia type 1, 2, 3 or Bethesda system low-grade squamous intraepithelial lesions, that's CIN type 1, and high-grade squamous intraepithelial lesions, CIN type 2 and type 3. Also present with natural history of CIN. So what are the morphological changes of cervical cancers? So this is the normal squamous epithelium of the cervix. This is where metaplasia has taken place. We have mild, moderate and severe. Here carcinoma is already in situ. So this is the normal appearance of the cervix. This is the appearance of the cervix in low grade CIN, and this is the appearance of the cervix in high grade cervical intraepithelial neoplasia. Let's move to the histologic types of cervical cancers. Basically have four histologic types of cervical cancers. The first is squamous cell carcinoma, which is the most commonly occurring 85 to 90% of cases. Under the squamous cell carcinoma, we had large cell keratinizing or non-keratinizing. We have small cell verrucous. Secondly, we have adenocarcinoma, which occurs in 10 to 15% of cases. Under it, we have typical endocervical, clear cell, endometrioid, adenoid cystic, also known as basaloid cylindrical, and adenoma malignum. Third is the mixed type, which is adenosquamous and glassy cell. Fourth is the other types, such as lymphoma, melanoma, sarcoma. These are the ones that occurs in other parts of the body and metastasize to the cervix, resulting into cervical cancers. So let's look at the types of growth. We basically have two main types of growth, which is the endophytic or ulcerative growth and the exophytic or cauliflower growth. The endophytic growth is the kind of growth that takes place internally and extends outward, while the exophytic or cauliflower growth is that which begins externally. So, how does it spread? It could spread due to direct extension, lymphatic spread, hematogenous, or transcolomic. Clinical features of cervical cancers. Cervical cancers are usually asymptomatic. They are accidentally discovered or discovered at screening. So the symptomatic ones present when A, there is ulceration of the cervix. This presents with bleeding, that's postcoital bleeding, bleeding after sex, intermenstrual bleeding, or postmenopausal bleeding. Presents with vaginal discharge, which is usually purulent, malodorous, offensive, and profuse. That's in secondary infection. B is systemic effects in advanced disease. So when the disease has advanced to some point, it presents with systematic symptoms, which are cachexia, which is the abnormal loss of weight, especially in cancers, urinary symptoms such as dysuria, frequency, incontinence, in especially in vesical vaginal fistula. They also present with rectal symptoms, e.g., pain on defecation. They also present with pain, usually late, low back ache, deep pelvic pain, sciatica, that's pain along the course of the sciatic nerve, and ureteric colic. They also present with pedal edema. So, what are the physical signs? Early cases may be seen as erosion or chronic cervicitis, that's inflammation of the cervix. Cervical lesions on speculum examination may be ulcerative or fungating. So, how do you make diagnosis of cervical carcinoma? You do it based on history. You take history, you do physical examination, you do investigation such as MRI scan, pap smear. So in the investigations, you do full blood count, you do renal function test, that's urea electrolyte and creatinine, you do chest radiographs, you do an ultrasound scan, you do CT, and you do MRI, and do intravenous urography, barium enema, lymphagiography, examination under anesthesia to take biopsy or to even stage, which involves cytoscopy, pelvic exam slash cervical biopsy, that's to do the histology, or even proctoscopy. So, what are the complications in cervical cancers? First is pyometria, which is the accumulation of pus in the uterine cavity. Second is vesical vaginal fistula, which is a condition in which The bladder and the vagina share a common epithelium. Third is recto-vaginal fistula. Here the rectum and the vagina share a common epithelium. Fourth is ureteric obstruction. Here we have hydroureter, that's urine in the ureter. We have hydropelvis, that's urine in the pelvis. We have hydronephrosis, which is urine in the kidneys. We have pyonephrosis, which is the accumulation of pus in the kidneys. We have uremia, which is the accumulation of urine in the blood. So when you find urine in the blood, it is known as uremia. We have hemorrhage, which is excessive bleeding, a finding in most cancers. We have cachexia, which is abnormal involuntary loss of weight. So what are the causes of death in cervical cancers? First is hemorrhage. Excessive bleeding, if not attended to, will result to death. We have uremia, which is urine in blood, if not treated well, will also result to death. We have cachexia, which is severe weight loss in cancer, which will also result to death if not treated properly. So how do you treat cervical cancers? First, you look at the aim. Do you want to cure or you want to do palliation? Palliation, this is just managing the signs and symptoms. So what are the modalities of treatment? You do surgery, V times hysterectomy. You can know more about V time hysterectomy in the previous videos. You can do radiotherapy or chemotherapy. The treatment of cervical cancers based on figure staging. So in stage 1A, the aim is to cure. It is safely treated by scopically directed cone biopsy with a knife, laser, etc. Cure is realistic. So in stage 1B to 4, aim is palliation. Here you do surgery, radiotherapy, or both. You also do chemotherapy by gaining importance, especially with radiation, known as chemoradiation, for patients fit for this more toxic option. If carcinoma is confined to cervix, surgery or chemoradiotherapy is equally effective. So premenopausal women have less morbidity with surgery. With disease spread outside the cervix, chemoradiation is usually the mainstay of treatment. So if carcinoma of the cervix has already spread outside the cervix, the mainstay of treatment is chemoradiation. So what are the complications of treatment? When you do surgery, this results to shortened vagina, difficulty with complete bladder emptying. When you do radiotherapy, there might be diarrhea, menopause, loss of vaginal elasticity, and narrowing. So if carcinoma of the cervix is diagnosed during pregnancy, especially early pregnancy, external irradiation is done. That's after abortion has been performed. This irradiation is done with caesium. Many surgeons will offer victims hysterectomy. So in case there is carcinoma of the cervical stump after hysterectomy, this results much worse. Intracavitary radiotherapy is prejudiced as intrauterine tubes can't be used. So what is the prognosis of cervical cancers? We have a 5-year survival by stage here. So people with stage 1 cervical cancers, 80% of them survive after 5 years. People with stage 2 cervical cancers, 74% of them survive after 5 years. People with stage 3 cervical cancers, at least 47% of them survive after 5 years. Then people with stage 4, 25% of them survive after 5 years. So how do you prevent cervical cancers? First, you do primary prevention, which is education and immunization against human papilloma virus. Here you can do Cervarix, bivalent or Gardasil or even quadrivalent form of immunization against human papilloma virus. So you also do secondary prevention, which is aimed at quick diagnosis. Here you do pap smear, visual inspection with acetoacetic acid or colposcopy, etc. Then there is also tertiary prevention, which is clinical care slash rehabilitation. So, guys, at the end of these lectures, it will do you good to remember that cervical cancer is the commonest cancer affecting women in the developing world. Over 75% of cases present late, hence they are difficult to manage. Human papilloma virus infection is central to etiopathogenesis of cervical cancers. Human papilloma virus, commonest sexually transmitted infection, and changes takes 10 to 20 years to cancer, affecting room for intervention. Mainstay of treatment is chemoradiation. It is largely a preventable disease if immunization is carried out and people are well educated about it. Thanks for listening.